It's now beautifully extended by his protege, Elliot Fisher. It shows that at American levels of supply of specialty services, we can find no evidence whatsoever that increasing supply produces better outcomes for patients at a population level. It just produces more use and more cost, but not better outcome. Look at this slide. It's a little complicated, from Elliot Fisher's brilliant paper in the recent Annals of Internal Medicine. This paper was summarized in an op-ed in the New York Times this Monday, and I've asked that it be copied. It'll be available for you tomorrow out on some tables. If you divide American hospital service areas into quintiles according to the intensity of their services, from the lowest quintile, the lowest 20%, to the highest one, the highest 20%, and then you study as the dependent variable the quality of care in each area several different ways, like finding out if people reliably get the care that they really ought to have scientifically, here's what you find. Quality does not change at all with quintile. More intensity does not get you any more quality of care until you reach the top quintile, the most cost, the most intensity. And there, for some very important measures, quality decreases. More is not better, and at the top levels, outcomes are worse. This is a frightening finding with imponderably large implications for American healthcare. In fact, nobody powerful in American healthcare seems to want to touch this one yet with a 10-foot pole. It's scary for me to think about this, but if Wenberg and Fisher are right, then the reason my first knee operation was done in the first place may well not have been because my knee problem was there, but because the knee surgeon was there. In fact, the same surgeon examined my other knee when I first went to see him, and he said it was tracking poorly and probably should be operated on sometime to prevent subluxation. Happily, we never got around to that, and my left knee on your right is just fine, thank you. That makes me also believe that the first surgery probably had something to do with causing the later cartilage problems, maybe not. Do I believe for a single minute that that kind surgeon secretly went aside and rubbed his hands together greedily and said, he, another knee I can get money on. Here's a medical student nerd and he doesn't know. Not on your life, absolutely not. I'd bet my life, in fact, I did bet my life, that that surgeon believed that he was going to do me good. I am sure of that. But the fact remains, now I know that I had useless surgery for a non-surgical problem. My surgeon and I didn't know that then. I have a screw in my knee for no good reason at all. I guess you could say my knee got screwed unnecessarily. Specification 2A is, please don't do that again. I don't want a single drug or test or visit or stitch or exercise regime that doesn't help me. You hurt me when you do that. I want you to promise that you don't do unproven, unnecessary things to me. I want you to act on evidence, not just on hope. Specification 2B is reduce the suffering that I have from my bad knee. It's the obverse of specification 2A. It is reduce the burden of disease. That's why I'm coming to you in the first place. This is job 2, just behind safety. This is a balance, I know. I can handle that. Maybe, for example, you could offer me the hope of especially great function with a brand new prosthesis that's a little less tested than the old standby, but a little more promising. I understand that sometimes risks and results are a trade-off. What I want you to do is to involve me in that trade-off decision. I can help you make it, but only if you let me help you make it. Now, once we've decided on what to do it right, please. Don't add to my pain by a complication. Please do choose your approach to anesthesia or the prosthesis itself or the postoperative recovery regime and so on based on science. Since my right knee is on your left, and vice versa, I want you to make sure that you don't get your signals crossed, please, on that while I'm asleep. I will give you credit if your response to my RFP tells me how you make sure to execute that clinical plan absolutely reliably. I will not give you a lot of credit by telling me that you value autonomy for your nurses and doctors. If that means that you don't use scientific evidence reliably, I will take off points for wide variations in your clinical activities from doctor to doctor. Here's a question I'd like you to answer, for example. Suppose the doctor who was supposed to operate on my knee on Tuesday morning got the flu on Monday, and so a different doctor had to do the operation. Would you guarantee to me that the same high-level quality of care, the exact same evidence-based care would happen anyway? When I got on the airplane to fly here to New Orleans from Boston on Monday, I didn't need to know the name of the pilot to have confidence in the trip. I want it to be the same on your operating table. This has a lot to do with your culture. Is it open and fair? And does it value input from anyone in the know? I want to tell you a little story. A year or two ago, when I was trying to plan ahead for this knee stuff, I went to see a surgeon who several friends of mine told me was a young up-and-comer. I'll call him Dr. Up-and-Comer. He told me that he could help me by doing a semi-experimental procedure involving removing a wedge of bone from my tibia and fibula, inserting a metal plate, and sort of lining the bones up better to align the stress pattern. Dr. Up-and-Comer did say, when I asked him, that no randomized trials had been done on this yet, but he was pretty sure it worked because he'd seen a lot of patients do very well. I believe that Dr. McCrae felt the same way about his operation 30 years ago, so I'm a little fussy about the evidence. Anyway, Dr. Up-and-Comer's plan didn't sound too good to me because when I saw a picture of it, there was a lot of hardware that would be left at my knee, plates and screws and things. And it seemed to me that might make it potentially harder to put the new knee prosthesis in that I would need later on when it came time for that, because the wedge operation was just palliative, it would just temporize. It was a simple question. Would all those screws make it harder to do the replacement later on? And anyway, I already had a screw. A little while later, so I went to see a different surgeon who friends told me was sort of Dr. Knee in a particular city, a knee man's knee man. I wanted to know what he thought. Should I have the wedge operation or what? So I asked him. Now, to get the picture, you need to see the setup in your mind's eye. There was me sitting on the table. There was Dr. Knee in the middle facing me. And behind Dr. Knee, out of his line of sight, but in my line of sight, was Dr. Knee's senior fellow. And it just so happened that he had trained with Dr. Up-and-Comer, the one who had recommended the operation with the plates and the screws. So Dr. Knee said that he thought that if Dr. Up-and-Comer thought that the new procedure would help me, that I should have it. So I said to Dr. Knee, but wouldn't that surgery now make a knee replacement later on harder with all those plates and screws in my knee? Not at all, said Dr. Knee, looking at me and shaking his head. But just then I noticed that the young fellow behind him was waving his hands at me, trying to get my attention and silently mouthing the words, "Yes, it would," nodding his head up and down. At that point, Dr. Knee turned around, and like a scene on Saturday Night Live, the fellow suddenly started smoothing his hair back. It's a true story. Now, when you answer my RFP, I want you to tell me why that would not happen in your hospital. How do you make sure that if the student nurse or the housekeeper in my operating room sees something that could help me, maybe even save my life, that he or she will speak up loudly and promptly and directly, and that the surgeon will praise that participation, not scowl? Explain to me how you will make sure that the team is really a team, that the communication channels are wide open, so that every patient, so that I get the benefit of all the best information, no matter who has it. So specification 2A says no needless pain. Don't give me needless pain by doing things that can't help me. 2B says don't give me needless pain by the converse defect, failing to do things reliably and consistently that do help me. Spec 2C is a special case of the other two. It reads, relieve my pain. Now, I'm a Stoic, but I'm not a Zen master. If it hurts, I want you to take the hurt away. That includes physical pain and emotional pain. I want you to relieve both. Physical pain you can get right by just using the science. I already know that from my own pain-free operations number 3 and 4. These were done with world-class pain control. I'm going to tell you where, because you should know. It was Virginia Mason Clinic in Seattle, Washington, where I went for those procedures. I had not a single moment of pain at any time at all. It wowed me. It made me even more upset about the gaps in pain control in our nation. A few years ago, my hero, Joanne Lynn, led an IHI collaborative on end-of-life care that focused on pain control at the end of life. When we started, we found that cancer patients in a major hospital who were admitted explicitly to relieve their pain waited on average 110 minutes before their first dose of pain medicine. We have good science. We know how to relieve pain safely. I want you to promise me that you will use that knowledge so that I don't suffer if I don't have to. No needless pain. Emotional pain is more subtle. We all have our own versions. My emotional pain gets worse when I'm alone, when I want to know something but no one will answer me, when I feel criticized or like someone thinks I'm stupid, or when I'm frightened. So your reply to my RFP, you're going to have to tell me how you plan to help me with that stuff. Will you promise me that I won't be separated from the people who love me? I will not hire any place that does not let my wife and my children join me in the intensive care unit, in the recovery room, in the emergency department, or anywhere I want them, anytime. Will you promise me straight answers to my questions, and will you stick with me until I finally understand your answers? You can see how this works. Visit Terry Clemmer's ICU at LDS Hospital. It has open visitation. It has one of the best approaches to family members I've ever seen anywhere. You can study it now at Geisinger Clinic in Pennsylvania, where Karen McKinley's been leading her medical ICU, though not yet their surgical ICU, to fully open visiting hours. Specification number 3 is no helplessness. I can maybe show you this better than talking about it. So you're laughing. Why are you laughing? Because I look ridiculous. It's a slippery slope from here to helplessness. I do look ridiculous. I look childlike, undignified, and vulnerable. That's what I mean by helplessness. Look how much you can take away from me when I agree to become your patient. You can take away my clothes. You can take away my privacy. You can take away my right not to be naked. You can put things in my body orifices and in my veins. You can take away my pills and give me your pills. You can harm me with an error and not tell me. You could read me your rules, but I cannot read you my rules. I am looking for a place that's different. The 2 most important ways to prevent my helplessness are to share information with me and to give me choices. First, keep me posted. That'll begin with my medical record. No one will be able to touch my knee who won't give me my medical record to read anytime I want, no questions asked, and no delays. Better yet, you give me my medical record to keep with me, and I'll let you use it anytime you want. To keep me from feeling helpless, to keep me from being helpless, you'll need to leave choices in my hands. You're going to need to find out the way I want things and adapt to me. You'll need to read my rules, not just read me yours. A close relative of mine in a hospital this summer was there for a very serious illness. She needed anticoagulation. She'd had a pulmonary embolism, and so she needed blood clotting tests every 6 hours. She also needed blood chemistry tests every 6 hours for a different problem. The problem was those 2 doctors' orders were put in at different times, and so the 6-hour intervals weren't synchronized. That meant that my cousin had 8 blood draws a day instead of 4. So I asked on her behalf that they synchronize the blood drawing. But the phlebotomy nurse refused to do that because the doctor had ordered it that way, she said. So the floor nurse refused to do that, and she looked pretty annoyed at me. And so they called the surgical resident, and he looked even more annoyed at me. He said that he refused to take responsibility for any risks that delaying one or the other of the blood tests would involve. That made my cousin so scared that she cried. Moreover, he told us that that meant that at 2 o'clock in the morning, he, not the phlebotomy nurse, would have to draw the blood. That's what I mean about helplessness. 8 needle sticks when it could have been only 4, blaming the patient and her difficult relative for asking that a moronic scheduling defect be repaired, shifting the burden to the patient, treating an honest, logical request as a bother. I don't think the resident meant to do that. I think he was in a context that made him do that. I'll tell you what I'll like. I want you to tell me how you treat patients' orders, mine, as respectfully and carefully as you treat doctor's orders. And maybe I'll let you get into my knee. If your feeling is, by the way, that that makes me a difficult patient, then save us both time and don't submit a response to my RFP. I guess I'd like an appendix to your application, please, that tells me how you make sure that all of your staff understand that you hire people who have the attitude the patient is the boss, and that you give them the tools to make it so. If I'm not going to feel helpless, by the way, I also need to be able to reach you later on, after I go home, maybe months later, maybe even years later, with questions and with suggestions. You make me feel helpless when you leave me confused and no way to get unconfused. I would really appreciate 24/7 answers, if you can arrange that. Email access to your doctors would work just fine for me, but who knows when I might feel worried. If you view discharge as out of sight, out of mind, I don't think you can get the job. My knee, or the metal knee that you're going to put into me, is hopefully going to be around for quite a while, 20 years maybe. And so I want you to remember me that long. It's interesting to me, and it actually saddens me, that the surgeon, really nice guy, who first did the wrong operation, never ever called me or followed up on me in any way at all to see how I was doing, which has at least a little to do with how he is doing. How can he learn about the long run? Did he think that I was done with my knee when he was? I will give you extra points if you have a total knee registry and if you use it a lot. I'll give you even more points if you follow patients regularly for years to understand the effects of your work on them over time. Specification number 4 is no unwanted waiting. This is sort of obvious. I want to tell you how to prevent delays of all types. I want you to prevent delays of all types. I'm really, really busy, just like you are. And for most things, the best waiting time for me is no wait at all. In your clinics, therefore, please use the advanced access models of Mark Murray and Catherine Tanto, like the Alaska Native Medical Center and Luther Middleford and Theta Care do, or Everett Clinic or the Veterans Health Administration, so I can get an appointment any day I want. In your hospital, I'd also appreciate it if I don't have to wait. So I want you to use the brilliant work of Professor Gene Litvak on how to smooth flow through your system. Maybe you could participate in IHI's flow collaboratives. You'd be welcome. That way, you're not going to leave me alone on gurneys in your hallway. You'll start my surgical case when you say you will. If you do a test, you'll store it and you'll retrieve it on demand. And if someone else already did the same test, you'll use that test instead of doing it again. You'll schedule my discharge in advance to the half hour, and I won't have to wait around for a missing doctor's signature because my meds haven't arrived yet. Now, I'm helping you with this one. This is my house in Newton, Massachusetts. These are the stairs to the second floor of my house. This is my bedroom. I guess those are my socks on the bed now that I look at it. This is my bedroom closet. And there are my sweaters. And behind my sweaters is my X-ray file. It has in it almost all of the X-rays, MRIs, CAT scans that have ever been taken of my right knee in the past decade. Some are copies. Most are stolen. It is a complete file. It is also a felony. So why am I a felon? Well, let's review the history. Since 1991, I've received surgery care or opinions for my knee in 7 different places, 6 in New England, 1 on the West Coast, from 11 surgeons and physicians, 4 physical therapists, 2 chiropractors, and a masseur. I have had 8 different X-ray, MRI, and CAT scan sessions in 5 different facilities. On no occasion at all did anyone who saw me have anyone else's X-rays or images to look at, only their own, except when I myself physically transported them. This required me to take time over and over again, traveling to hospital file rooms, filling out forms, waiting while they searched. On 2 occasions, when I tried to borrow films to transport them, the facility told me that they were lost. So I figured, well, why not lose them to me? I mean, they're no more lost than they were before, except that now at least one person knows exactly where they are. So since I became a felon, every single clinician that I've seen about my knee has had every single image that was ever done in the past 10 years. The Berwick right knee imaging retrieval system has become 100% reliable. And the delays waiting for people to find or fetch films have fallen quite low, to 0 in fact. Well, not quite to 0 because my closet's a little messy. It can take me a few seconds. Now, this is a warning to the young people. I am not advising you to steal your own X-rays and medical records so as to improve reliability, decrease helplessness, drive delays to 0, while also saving hospitals, clinics, and yourselves the costs and delays of retrieving and tracking down lost items. That would not make any sense, would it? I believe that in the military health command, I'm told, patients usually can store and carry their own medical records. Specification number 5 is no waste. Now, do I really care about that one? After all, my health insurance is pretty good, and if you want to raise your costs by creating scrap or wasting materials or duplicating efforts, isn't that your problem, not my problem? Of course, the good citizen in me wants you to reduce your costs by reducing your waste. European healthcare systems, some listening today, tick away at 1/2 the cost of ours. These are some recent figures from Uwe Reinhardt. The OECD nations give comprehensive, universal health care at $2,000 per person per year, while we're spending $4,800. I am astounded by the myths chiseled into concrete in the minds of Americans about these differences. The myth that people flock to us for care they can't get in Canada or England. The myth that these other systems are disciplined by rationing that we don't accept. Those myths are wrong. It is one of the great frustrations I have as a student of improvement that I cannot seem ever to win the attention or the curiosity of American healthcare leaders to study and harvest bold new ideas from non-US healthcare systems. The answers we need for America's healthcare do not lie in our normal experience. They lie outside our normal experience. The knee surgery outcomes in Sweden are good at $2,000 per capita per year. I think they're better outcomes than ours. I know that their post-operative care is more integrated than ours. I've been there. I know they have a national knee registry, an arthroplasty registry, with over 70,000 entries. In your response to my RFP, maybe you'd like to tell me how you are learning from other nations about how to make better care with less money. If you answer that question, by the way, you'll probably be the only respondent who does. But actually, my knee and I have a somewhat more selfish reason to ask you about waste. It relates to something that our keynote speaker tomorrow, Paul O'Neill, first told me. I've learned so much from him. It's the importance of what he calls a habit of excellence. He thinks, and I agree, that excellence in a system, if it is going to be reliable, cannot be divisible. You can't say, be excellent here, but it's okay to be sloppy over there. And waste is a symptom of defective process. It is non-excellence. I want my knee in the hands of a people and a place who are intolerant of the disorder, duplication, unpredictability, and inattention to detail that lie at the root of waste. Because then I can predict with more confidence that my care may be orderly, coordinated, anticipatory, and attentive. I want my care from a place where the habit of excellence creates a sheen, a leanness, a sensitivity in real time, a calmness, a steadiness that no glutton system can seek or understand. I have to tell you that when I read finally my whole RFP overall, I really got nervous. It's asking for a lot. It is, as I told you, very, very self-centered, and I know that. It leaves me with two big questions. The first question is, does anyone want to answer it? And the second one is, can anyone answer it? I can't help you with that first question. Do you want to pay attention to me? I've thought about it, but I can't make anyone want to serve me. That is your choice, not mine. If I ever could actually issue an RFP and take my money with me to a winning applicant, I would do that. With one shot left between me and cross-country skiing, I have got to take the best shot. But you and I both know that I really can't do that. And for the poorest people in this country, especially, they can't do that. I can't really shop, not much. Healthcare is a niche market, and my choices are very, very limited and broader than most. In fact, the only thing more limited than my choices is the information on the basis of which I would choose if I could choose. That's changing. I hope it's going to change pretty fast. I think that transparency about results seems more and more important to me as I get older and as my bone on bone wears away. I was intrigued that even though nobody made them do it, John Toussaint and George Kerwin and others in Wisconsin, 8 organizations have taken it upon themselves to publish their own performance data, warts and all, and a whole bunch of indicators, more over time, as part of the Wisconsin Collaborative for Healthcare Quality. I applaud them. That's one of the places in the country I could actually make some choices on the things I care about. I just wish I could do that for my knee. So I will turn to my second question. Is this just fantasy, Or if you wanted to do it, could you? If anyone wanted to meet my specs, could they? And here the answer is easy. It's yes. Nothing in my RFP, nothing at all is out of reach. For almost every detail, in fact, I know a supplier right now. I can avoid surgical infections almost to the theoretic limit if I go to Intermountain Healthcare. I can avoid ventilator-associated pneumonia now if I go to Dominican Hospital in Santa Cruz. My indwelling IV line won't get infected at Baptist DeSoto Hospital. My wife and my kids can visit me anytime, day or night, in the medical ICU at Geisinger. If I were cared for in the Military Health Command, I think I could carry my own medical record, and I could read it anytime I want. I might have no pain. I did have no pain at all at Virginia Mason. My primary care delays would be zero because of open access schedules at Luther Middleford or ThedaCare. My specialty delays would be continually falling now at the Alaska Native Medical Center and South Central Foundation in Anchorage. I could wear my street clothes in a Plaintree unit. I could get to my doctors through email in an increasing number of locations. At Eksjö Hospital in Jönköping County, Sweden, the cost of my care would be 40% of the US costs. I would have the same or better outcomes, demonstrably lower complications, and much more coordinated rehabilitation than I could find anywhere here. My care would be integrated across inpatient and outpatient settings by an electronic medical record in the VA system, and by digital radiology in parts of the Indian Health Service, which would allow me to clean my closet out. In 10 years of hard work, you see, we have altogether brought healthcare from the state of having no cloth to the state of having no quilt. The patches are made. The stitching is the problem. Look around you, almost everyone in this room has a piece of the answer. I could have exactly what I want if I could cut myself into pieces. I could get my respirator care at Dominican, my IV line at Baptist, my medical record at Washington Medical Center, my pain control in Seattle, my appointments in Anchorage. I'd have the transparency of the Wisconsin Collaborative, the respectfulness of Plaintree, the orderliness and sparseness of Jönköping, the teamwork and the amazing nursing morale at Hackensack or at North Shore Jewish, the flow management of Mayo Rochester, the email system of Dr. Gordon Moore in Rochester, New York, or Dr. Chuck Kylo in Portland. I see what I want, I see what I need. It's just scattered all around. So someone, please now, can you put it all together?